Hey guys, this is Dr. Singh. I'm doing some USMLE question analysis today for the USMLE Step 2 and Step 3. The point of this exercise and this series is to just get familiar with some of the questions, how questions are structured, how to get through them quicker and more efficiently, and then go through some of the topics that the USMLE is trying to test for and how they would be trying to trick you. So without further ado, let's start with the first question. Okay, so we're always going to start with the last sentence of every question. That's kind of just like the basics of USMLE. If you guys have taken step 1 or level 1, you know that you got to go there first. A lot of the times you can answer the questions with just, one line or some basics rather than going through the whole paragraph. So I like to know where the question is headed before I read the whole thing. So it's asking which of the following is the most likely to improve the patient's cognition and movement disorder. So already I'm thinking, okay, something's wrong with this guy cognitively. Is this a primary neurologic issue? Something's wrong with his brain. His brain is down in some way. And so I guess what's the cause of that? Okay, so a 68-year-old guy, he's brought to the emergency department because of a 2-day history of progressive lethargy and tremors. Okay, so 2 days of being a little tired and tremulous. Right now, differential is super broad here, so we'll read on. He has alcoholism, opiate, cocaine, and methamphetamine use disorder, but he has abstained from alcohol and illicit substances during the past 2 weeks. So we're going to take this question primarily at its word, although in real life you wouldn't take this person for their word, unfortunately, just because it's just how people are. People lie. But we're going to take this guy at his word that he's not drinking anything or doing anything. He also has alcoholic cirrhosis. Okay, now a couple things are going through my head as far as being cognitively down. So differentials are, we should currently be thinking of, any sort of intoxication of any of these drugs or alcohol. We should be thinking of withdrawal. He shouldn't be withdrawing if he drank 2 weeks ago, but let's just say he's lying. He could be withdrawing. Other causes of altered cognition in an alcoholic person with cirrhosis specifically would be hepatic encephalopathy. So next, his only medication is a daily multivitamin. He previously drank 6 12-ounce beers daily, so this daily multivitamin kind of useless. This next sentence is telling us, yeah, he drank a lot. Great. He appears chronically ill and is somnolent. Okay, so this is kind of like their first hint at how kind of what he looks like. Next are vitals. Temp is normal, 98.2, which is good. Doesn't have a fever. Pulse, he's borderline tachycardic, so his heart rate's a little fast. Respirations are 18 and blood pressure is 100/60. Pulse ox shows O2 sat of 94% on presumably room air, so pretty good. So in the vitals, the only thing that really sticks out to me is that he's a little tachycardic. Everything else looks okay. When someone is cognitively down or someone is quote unquote altered or presenting with altered mental status, in real life, the first thing I'm looking at is, okay, is he altered or confused because, he's hypotensive or his vitals are abnormal? So it doesn't seem like that's necessarily the case. Other than this mild tachycardia, he's doing okay. Now, exam. Exam shows conjunctival icterus, ascites, and 2+ edema of the lower extremities. Cranial nerves are intact. Strength is 4 out of 5 throughout. When he is awake, there is a postural and action tremor of his forearms and hands that is accompanied by a sudden, brief loss of muscle strength. Okay, so let's just go through the rest of the exam. So the exam, if you guys want to pause for a second and just think about what this exam is trying to tell you. Conjunctival icterus is telling us that he's essentially got jaundice. Conjunctival icterus is how they say jaundice of the eyes. Ascites, another kind of sequelae or physical exam finding of liver cirrhosis, and then 2+ edema as well. Strength being 4 out of 5 You're classically going to see that someone's got a low muscle strength. I'm thinking of like a neurologic issue. But again, I guess how would you differentiate something like a stroke versus what's going on here is, well, he's 4 out of 5 throughout. So again, he's generally down. His whole body is weak and down, rather than, let's say, his left arm being 4 out of 5, then we would be concerned for a stroke. So again, exam is showing me liver cirrhosis. So all in all, so far I'm thinking about, especially with this exam, plus what we first read about his cognition being down, my immediate thought is hepatic encephalopathy. Okay, and so we have diagnosed hepatic encephalopathy by the end of this exam. So when he's awake, there's postural and action tremor of the forearms and hands that is accompanied by a sudden, brief loss of muscle strength. So what they're describing here is, if you guys want to pause the video and just think about it for a second, is asterixis. So this is just asterixis, or the flapping tremor that you can commonly see in hepatic encephalopathy. You can actually see asterixis in a few different metabolic encephalopathy. So you can actually see that in renal failure, where you have very high BUN in like the hundreds. You can also see that in hypercapnic encephalopathy. So when someone's got a PCO2, they're retaining CO2. So those are kind of like the 3 reasons for someone to have asterixis. But again, this is really just supporting our thought of hepatic encephalopathy. His speech is normal, and he is able to follow simple commands. Serum total bilirubin concentration is 3. Okay, so this is kind of backing up the fact that, hey, this guy's got liver cirrhosis. So kind of just another data point for us. Blood and urine cultures grow no pathogens, so they're trying to sell to us that, hey, there's no infection that we see currently, and we probably would agree with that there's no fever, but although his heart rate's a little high. So which of the following is the most likely to improve the patient's cognition and movement disorder? So I think there's a lot of data in here to support that this guy's got hepatic encephalopathy. And so what I would want to do is, if you guys want to pause the video and just think about it for a second, but I would choose oral lactulose therapy, answer C. Now, let's just go through the other answer choices and kind of analyze why we think they're incorrect. Intravenous vancomycin and cefepime therapy, sepsis or an infection is certainly on the differential when someone is altered and they're tachycardic, when their heart rate's high. Liver or cirrhotic patients, excuse me, cirrhotic patients do have, they are at increased risk for infection, like a lot of people with chronic diseases. But we would see some source of infection. So they would say something like, this guy's got urinary symptoms, or his urine cultures would have grown back something. You would have some sort of cough to represent pneumonia. You would have had some sort of abdominal pain or tenderness on exam to represent maybe SBP, or spontaneous bacterial peritonitis, especially in a cirrhotic who's got ascites. Or some sort of urinary symptoms to represent UTI. But we don't see any sort of focal sign of infection necessarily. The lack of fever certainly helps us, although you don't have to have a fever every time you have an infection. So I think infection is less likely in this case, certainly. So A is out for me. B, IV thiamine therapy. It's actually a pretty good answer. So really, if you guys want to pause for a second, what is the treatment? What does IV thiamine treat? Well, IV thiamine treats Wernicke encephalopathy. And Wernicke encephalopathy is, this guy is a perfect candidate to have Wernicke encephalopathy. He's an alcoholic, he's chronically ill, probably has has malnutrition, he's a cirrhotic. So all of those things kind of favor him, having a chance to have Wernicke encephalopathy. The classical teaching for Wernicke encephalopathy is a beer can. So a can of beer or a beer can. So The C is confusion, which he has. A would be ataxia, and N is nystagmus. And so, they would sell that pretty hard in the question. So he is confused, but he doesn't really have ataxia necessarily, but in real life, that's kind of hard to differentiate if someone's got ataxia or not. If they're so confused, how are they going to walk, right? How are you going to elicit that out of them? But in the question, they would have said something about, troublesome gait, difficulty walking, recurrent falls, something like that. And then nystagmus is pretty easy. You can check for that while they're laying in bed. So it doesn't really have that. So IV thiamine is out. And then letter D, lorazepam therapy. Lorazepam therapy, you guys want to pause for a second. What would lorazepam therapy treat? So lorazepam therapy would be treating alcohol withdrawal. So alcohol withdrawal, we're going to, I'm pretty sure you're supposed to take these questions at face value and not assume the patient is lying or the question is trying to lie to you. So they're saying that the patient hasn't drank in 2 weeks. So the odds of someone withdrawing 2 weeks later from their last drink, very, very unlikely. When someone withdraws, it's usually, between 2 and 5, between 2 and 7 days at its max is when they would start to have withdrawal symptoms. Typical withdrawal symptoms, confusion is one of them, certainly. You would have tremors, confusion. You can have tongue fasciculations. You can also have some psych symptoms as well. So hallucinations, auditory and visual, kind of psychotic disturbances. The other thing that you'd be looking for in alcohol withdrawal and delirium tremens is abnormal vitals. So the vitals you look out for are fever, tachycardia, so high heart rate, and hypertension, so high blood pressure. And so that's what they would try and sell to you. So if they said, this guy's last drink was 3 or 4 days ago, and his vitals are deranged, he's got a fever, he's tachycardic, his blood pressure is a little high, he's hallucinating, he's seeing things and talking to the wall, and he sees cats, then I would say, okay, that's probably more likely to be alcohol withdrawal than hepatic encephalopathy. I have a couple of learning objectives, although we've kind of gone over a few of them. So I recognize the sequelae of liver cirrhosis. So on exam, seeing if this guy's a cirrhotic or not, right? So the diagnosis of hepatic encephalopathy for us really hinges on a couple of things. His physical exam, so, signs of portal hypertension like ascites, lower extremity edema, signs of hyperbilirubinemia, so scleral icterus, and then on labs, elevated bilirubin. We can't really make a diagnosis of hepatic encephalopathy without liver cirrhosis. So if a guy is just an alcoholic, but he's not a cirrhotic, meaning you don't see any of that on exam, his labs look pretty good, imaging evidence of liver cirrhosis is not there, well, then it's probably hepatic encephalopathy wouldn't be the cause of him being so altered. So having those sequelae of liver cirrhosis there really pushes us towards the direction of hepatic encephalopathy as a diagnosis. Recognizing hepatic encephalopathy, like we said, we talked about the mimickers already, but alcohol withdrawal, we talked about intoxication, so just a guy being drunk can let them be altered. The other intoxication, so the sympathomimetics or the sympathetic activators like cocaine and amphetamines. Important to know how those present. We don't have to go through those right now. And then Wernicke encephalopathy we talked about. Next, step 2 and step 3 is going to ask this treatment of hepatic encephalopathy. So first line treatment is lactulose plus or minus rifaximin. In clinical practice, we're usually doing both. And so, another way they can ask this is just say, instead of saying which of the following is most likely to improve this patient's cognition, is say, which of the following is the mechanism of action of the most appropriate therapy. And so on step 2 and step 3, they do ask questions like this. So lactulose, the mechanism of action is essentially you're preventing the absorption of ammonia. The way you're doing that is lactulose is going inside the gut, and it's converting ammonia to ammonium, which is NH4 is ammonium, and ammonium NH4 cannot be absorbed by the gut, so that gets excreted and you kind of just poop it out. And so that's kind of how lactulose works, and they can kind of ask that in any way. So, we spent 15 minutes talking about this, but I think there's a lot of good stuff here. If anyone's got any questions about something I said, or if there's an error, please comment down below. I would be happy to fix it. Please comment down below if there's any questions you'd like me to review that have a lot of good physiologic and pathologic concepts. For any of the steps, step 1, step 2, or step 3, I'm happy to do it. Kind of helps me with my own learning. And I just want to provide as much value as I can. So thanks so much, and I'll see you guys next time.